I'm going to discuss the management of catheters in persons with spinal cord injury and the prevention and treatment of the bladder infections and associated problems that they have. I'm first going to talk about how I got involved in this. As a urologist, I see persons with spinal cord injuries periodically. They would come to my office with bladder infections and stones and skin wounds and various problems. I was always frustrated about what I was able to do for these people because I could treat the acute infection, but within a few weeks they were right back where we started with chronic infections and more stones. So a few years ago I talked to an acquaintance of mine who is a professor of urology at a major research university, his specialty is bladders, and I said, is there anything more that I can do to help these quadriplegic patients that I'm seeing? And he said, no, there's nothing to be done. I've tried, I've worked with the patients, and nothing works, and I don't see them anymore. So okay, if he couldn't do anything, then I felt it was a waste of my time to try to deal with this, and I would just refer these patients on. Well, then about 2 years ago, a young man came in with his mother who'd had a C4-5 spinal cord injury and quadriplegia. He was having bladder and urinary tract infections, stones with obstruction of the catheter, skin wounds. He'd had 2 ICU admissions in the previous year. And my first inclination was, okay, I'm just going to refer you to Pittsburgh. But I started talking to them, and they'd already been to 3 or 4 urologists and 3 or 4 rehabilitation centers, and nothing had changed. So I said, okay, I don't know what to do at this point, but if you'll work with me, I'll try to figure out something to maybe make your situation better. Okay, so these are the problems that patients have who have chronic inguinal Foley catheters and spinal cord or other types of paralysis. They have bladder stones, and these stones can form small gravel and encrust and block or obstruct the catheter. The catheter obstruction in patients who are susceptible makes them prone to autonomic dysreflexia, they're prone to sepsis, and the pressure ulcers that these patients are prone to anyway become infected. They're frequent hospitalizations, and because they're sick all the time, they have a poor appetite, poor nutrition, they're debilitated because the body is using its energy to fight infection and inflammation instead of to build the patient's strength up. Now, I'm going to go through all of these more or less one by one. Bladder stones are caused by bacteria that produce the enzyme urease. The urea in the bladder is broken down by the urease enzyme that's produced by certain bacteria into ammonia and CO2. The ammonia combines with water and forms a positive ammonium ion and a negative hydroxyl ion. So bladder stones, or what we call infection stones, are made of magnesium ammonium phosphate. So we're increasing the concentration of ammonium, and the hydroxyl ion increases the pH, makes the urine less acidic, and that makes the phosphate in the urine less soluble. So the phosphate precipitates out, and we get increased phosphate. So then we get the magnesium ammonium phosphate stones. And this has nothing to do with the patient. This is the bacteria that are causing these stones. Okay, now this is some imaging studies on another patient who came to me. This is a 76-year-old gentleman who had a paraplegic accident about 25 years ago. He was able to void on his own, although he was a little incontinent. And he had some other injuries at the time, but this is an ultrasound in 2006. This is posteriorly, this is his rectum, this is his bladder, no stones. This is an ultrasound of his left kidney taken in April 2008, no stones. It was at this point where a Foley catheter was inserted because they were having trouble healing his skin wounds, and they thought that by getting rid of the urine and the sacral area that would help. I saw him last fall in September, and he'd been having recurrent infections and hospitalizations. He'd been in ICU when I first saw him. Okay, a CT scan, here's his bladder, full of stones. Left kidney, full of stones. It's a staghorn calculus. Okay, so again, this is the list of problems that occur in patients with long-term Foley catheters. If they have stones and the stones obstruct the catheter and cause bladder distension, and if they have a spinal cord injury above T6, they're prone to autonomic dysreflexia. What happens there is the bladder becomes distended, and that's painful. The patient cannot perceive the pain, but the body reacts to the pain. Now the sensory nerves, the autonomic sensory nerves from the bladder run outside the spinal cord. So they go up to the central nervous system and stimulate an epinephrine reaction. So there's a big output of epinephrine, the arteries clamp down, blood pressure rise. There's a sudden severe elevation in blood pressure, causes headaches, and they don't feel well, and this blood pressure can be very severe. Now, in a normal person, autonomic motor signals pass down the spinal cord and would counteract this extreme reaction. But in the spinal cord injured patient, of course, the motor signals cannot go past the spinal cord injury. So the high blood pressure progresses without inhibition and can become life-threatening. Okay, at the present time, the way patients are managed who have an acute spinal cord injury is that they're immediately sent to a very specialized spinal rehabilitation center where the acute problems are dealt with. They usually have neurosurgery, patients stabilized, and then they're taught to use a wheelchair and a few things about taking care of themselves. And usually after about 2 months, they're sent home. And these specialized rehab centers are very good for the acute care. But once the patient goes to their home community, there's no organized follow-up care for this condition. And both primary care physicians and specialists out in the community have very little experience with these types of problems. And after a few months, the patients are having problems with infections and all the associated things with it. They're usually not able to get very far with their local medical care, and they're very frustrated. And the final thing about this is that anybody's system can be affected by these severe spinal cord injuries. But if you go on the blog sites that the spinal cord injury patients have to communicate with each other, and they talk about their problems, the most common problem they have is bladder infections and bladder stones. Okay, so this, so what happened at this point is I went to the literature and, actually I skipped a slide, okay. I went to the literature and tried to figure out anything additional I could do. And surprisingly, there's nothing written in the urologic literature about bladder infections in spinal cord injury patients. And the rehab centers are not interested in it because the physiatrists are primarily interested in muscles and nerves. But one of the first things I discovered was biofilm. I'd heard a little bit about this, but I really didn't understand it. Since we discovered bacteria, we've thought of them as single-celled organisms, just floating in the urine or wherever they happen to be. But recent research has shown that most bacteria in nature, and probably in human disease, is caused by bacterial biofilms, bacterial colonies that form a highly structured and complex organism. Individual bacterial cells are capable of sending signal messages back and forth and communicating with each other, and they do what's called quorum sensing. So they can tell when there's a certain mass of bacteria in the vicinity, and at that point they start to form a biofilm. Biofilm is made up of a polysaccharide matrix. It's a complex sugar molecule that forms a kind of a scaffolding in which the individual bacteria are set and are protected from the environment, so that the body's defenses, such as antibodies and white blood cells and antibiotics, cannot get through this matrix to the individual bacteria. In addition, these bacteria undergo specialization, and some of them will specialize in collecting nutrients, some in eliminating waste, some in enhancing their defenses, and so you have almost like a multi-celled organism with different cells having different functions. And they're actually able to exchange DNA, so there are genetic differences after a while between the individual cells in these biofilm colonies. And biofilm forms very rapidly on foreign objects such as Foley catheters, and particularly on the latex rubber, which is an organic compound. Okay, so here's what happens with biofilm formation. The individual cells, what the microbiologists call planktonic cells, floating freely in the urine. This surface we will call a Foley catheter. So some of these cells attach to the surface of the Foley catheter, they grow and multiply, and eventually start to form a biofilm colony. And this goes on and grows into a very complex organism. Okay, this is another view of what happens. These cells are the cells lining the bladder wall. Here's a bare area. There's been an injury, perhaps caused by a catheter. The white ovals are individual bacterial cells. The green crosses are antibiotics, and the yellow ones are antibodies. And they attach to the bacterial cells and kill them, okay? They have a white blood cell or leukocyte that engulfs some of these cells. Nevertheless, some of them are able to attach to the lining of the bladder and form a biofilm colony. So the black ovals are individual bacteria within the biofilm colony. The antibodies and antibiotics cannot get at them. The white blood cell cannot get at them. The white cell then starts to secrete phagocytic enzymes which would destroy the bacteria, but again, the bacteria are protected, but these damaging enzymes attack the bladder cell, the cells of the bladder wall, and cause damage to them and make the bladder more susceptible to infection and to sepsis. Another view, there's two bacteria that are set within the biofilm scaffolding or matrix, and they are able to produce a hollow tube between them. They can pass nutrients, signal molecules, and fragments of DNA through this tube. Okay, another view, here's the fluid, the urine in the bladder. You have individual bacterial cells floating freely. They land on the surface and attach to the surface. In this case, it would be of a Foley catheter. They start to form a biofilm colony, which then grows into a very complex organism, can produce daughter colonies which can float elsewhere and cause further infection. Here you have an area that's producing large amounts of single-cell bacteria that can go produce more infection or more biofilm colonies. Okay, this is just to show how common this process is. This is the air cell or the alveolus of a lung. And you have some individual bacteria being attacked by antibodies and antibiotics. Nevertheless, this particular bacteria is able to start a biofilm, which then grows, and when it reaches this stage, there's no air exchange. And this is what happens in cystic fibrosis. The patients cannot raise the fluids out of the lower part of the lungs, so these bacteria accumulate, the biofilm accumulates, and that's why they're given these chest vibrators to wrap around themselves, which will break up the biofilm so that they can cough it up. Here's another situation which explains why we sometimes do not get a complete picture of the infections we deal with. Here we have an infection that's got both biofilm and some individual bacterial cells. The physician takes a specimen of this and puts it in a transport test tube. Now the individual cells will float freely in the fluid, but the biofilm colony fragments that are put in here attach to the walls of the tube, and when the lab technician puts her pipette in and takes out the fluid, we get the individual cells, but not the cells in the biofilm colony. So we have an incomplete idea of the infection that we're dealing with. Okay, so once we understood biofilm theory, there were three things that suggested themselves for dealing with the patients and their problems. One is that the catheter be placed in a location that minimizes the introduction of bacteria into the bladder. The second is that the catheter be resistant to bacterial colonization. And the third is that the catheter be changed often enough that large amounts of biofilm cannot form. Okay, to take the first point, I usually use a suprapubic insertion site. I make a small incision in the lower abdomen and pass a catheter into the bladder. Once that incision heals, that catheter can be changed whenever necessary. And this site has several advantages. It's away from the perineum and genitalia so that there's less bacteria, less contamination. For people in a wheelchair, it's much easier to change the catheter. They don't have to get out of their wheelchair. They don't have to take their clothes off to have their suprapubic catheter changed. And finally, this area is easier to clean and prepare than a genital area in the urethra. Okay, secondly, there's some new catheter technology that is more resistant to bacterial attachment. We've been using latex rubber catheters for over 100 years, but latex is organic and toxic. Bacteria can attach very easily to it. The latex is toxic to the bladder. If you lay latex against the wall of the bladder, it causes damage to the bladder cells, making them more susceptible to infection. Silicone is inert and non-toxic, and silicone catheters have been around for a while, but at first they were very stiff and they never really took off. They were uncomfortable to use and to manage for most people. But recent technology has produced more flexible silicone catheters, and these have been more acceptable and work well in these patients. In addition, they have added antibacterial substance to the surface of these catheters. Usually it's a silver compound, so that when the catheter is placed in the bladder, silver ions are released and they kill individual bacterial cells that are floating near the catheter. And finally, they come in catheter trays in which the catheter, the tubing, and the drainage bag are all pre-connected so that you're not having to manipulate these different parts, which again would promote contamination of the drainage system. Finally, the frequency of catheter changes. No matter how careful we are, biofilm cannot be prevented indefinitely. Most patients are told when they leave the rehab center to change their catheter once a month. But this is a long time, and a lot of biofilm is able to form. Weekly catheter changes result in a much lower volume of biofilm formation, and it reduces the frequency of infection and stone formation and all the other associated problems. Now this is a graph which unfortunately didn't scan too well, but what it is it's a bacterial separation study done at the Center for Biofilm Engineering at Montana State University, where most of the early research on biofilm was done. And they were testing 3 separate catheters to see which one resisted bacterial colonization the best. There was a pure silicone catheter, there was a latex catheter with a silver coating, and there was a silicone silver-coated catheter. So these first 2 catheters, okay, on the vertical axis here, this is the percent of the surface of the catheter that's covered in biofilm. Horizontal axis is time in days. So as time goes by, a greater amount of the catheter is covered with biofilm. And with these 2 catheters, in 4 or 5 days, the great majority of the catheter is covered with biofilm. With the silicone silver-coated catheter, at 7 days, a minimal amount of biofilm. Same study, they used several different bacteria. E. coli here, which is what was shown on that previous graph. On this graph, the vertical axis is time, and here we have the different species of bacteria. With the E. coli again, after 7 days, the silicone silver catheter is still resisting bacteria, whereas the other 2 catheters, after 2 or 3 days, have significant biofilm. With Enterobacter, much less aggressive in this situation, so all 3 catheters do it. But with Proteus, which is the primary stone-forming bacteria, after 2 days, these bacteria, after 3 days, the silicone silver catheter is coated with biofilm. So if these patients have an infection, you're much better off to have these bacteria here than these here, which is why we don't like to give antibiotics all the time, so that we select out these more aggressive bacteria. So this study shows 2 things. It shows which catheter resists biofilm formation the best, and that's the silver-coated silicone catheter. And it gives an idea of the time that we should leave the catheter in before change. As you can see, for most of these bacteria, 7 days is a good time period. Okay, these are some further points that I've discovered as I work with these patients. Many of these patients who have bladder stones are told to irrigate their bladder with an acidic solution to prevent the stones. The theory being that the acid solution will counteract the alkaline hydroxyl ions that are produced in that formula I showed you on stone formation. However, with this program, the patients do not form stones, so it's not necessary. In addition, the bladder irrigations tend to introduce bacteria into the bladder and increase biofilm formation. I like to use the 2,000 milliliter drainage bags, particularly for persons in a wheelchair. The bag can be put under the seat of the wheelchair unobtrusively, and it does not have to be emptied so often. For the suprapubic silicone catheters, the silicone catheters are stiffer the larger they are. So if they're too stiff, they cannot bend and be flexible under the clothing and are hard to manipulate. If they're too soft, they tend to kink. An 18 French usually works best for this situation. And a significant amount of time needs to be spent with their patient and the caregiver in teaching and demonstration. These concepts and techniques are foreign to most lay people. They're very intimidated and apprehensive about this, so it takes some time to make sure they understand what to do, how to do it, and they usually need some moral support at the beginning. But once you get them on the right track, it saves a lot of problems down the line. So in conclusion, it's the presence of bacterial biofilm on the chronic indwelling catheters that's the main cause of infections, stones, drainage problems in these patients. By minimizing the introduction of bacteria, by using bacterial-resistant catheters, and by changing catheters weekly, these problems are greatly reduced. The associated problems with skin wound, and poor nutrition, poor immune function, debilitation are decreased because their appetite is improved, they have less infections. A skin wound takes 30% of body energy, 30% of the calorie intake just to heal that wound. So that doesn't leave much left to build up strength. The immune system gets run down, and you get into a vicious cycle of repeated infections and debilitation. Once the infection's cleared up and their strength is regained, they can be included back into the economic and social life of the community. A person with a spinal cord injury is disabled, but they don't have to be an invalid. What makes them an invalid is the infections and all these other problems that go along with it. When those problems are cleared up, they have the strength and the will to go out in the community, pursue their education or employment in most cases. The two patients that I've mentioned here, first the student who had the cervical spine injury, he did very well on this program. His skin wounds healed. He's not had any further hospital admissions. He's gained weight. He's now back in college. He's majored in math and economics and #1 in his class. The elderly gentleman with the stones, I started him on this program, and even before I removed the stones, he started to improve. His appetite improved, strength improved. In 2 months, he gained 20 pounds. Okay, here are some references. Scientific American is a short, clear article that gives the basic information about biofilm. That's by Costerton, who did the original research on this. The Biofilm Primer is a short book, and if you're really interested, this gives you a very thorough idea of this problem and how common it is. There's an article on biofilm and urinary tract infections, and this is a case review which I published last fall concerning the first patient, and it reviews the entire program that we go through to treat these patients.